Hi guys, this is Jody and this is your video for week 3 Farm. We're going to talk about things that fall under neurological disorders part 2. Please make sure you go through ATI Farm Made Easy and complete that module. First, we're going to talk about drugs that are for anxiety disorders. So in order to really understand drugs that treat anxiety, you have to understand a bit about anxiety. So what are the symptoms? I'm sure some of you understand because I know many people suffer from some forms of anxiety, but you can see all types of symptoms, including the ones that I have listed here. Let's see, trouble concentrating or thinking about anything other than present worry. So this is something that needs to be treated. So sometimes we have anxiety based on a situation. So it's more of a situational anxiety. And then you have people that just have this anxiety that comes out of nowhere that does require some type of medication therapy. And before we ever talk about medication therapy for anxiety, depression, we always want to think about some non-pharmacological interventions as well, okay, before we start getting into medications. But there are different types of anxiety disorders, including panic disorders and all of the other ones that I have listed here. I can tell you for sure that separation anxiety is something my poor dog suffers from. But, you can see this, all sorts of different types of anxiety disorders. So benzodiazepines are, a big drug that you will see used for anxiety. This is a controlled substance, and 2 of the medications that you will see here are diazepam and alprazolam. So these are CNS depressants. So if you think for a minute about things that are going to depress the CNS system, that are going to make us less alert, what are some of the things that you think of right away that you need to teach your patient in order to be safe? Because there are definitely some safe things. So, pause the video here just before, I get into the list. Think of some things on your own that you might think of for safety. And so there are a couple things that you should be thinking of, like fall precautions when somebody is taking a CNS depressant, not taking CNS depressants with other things that depress the CNS system, like alcohol. And then there are things with benzodiazepines that you really need to think about. So we need to taper the dose if somebody is coming off of long-term use of benzodiazepines, okay? If they stop these drugs abruptly, they can have withdrawal symptoms. If you are giving IV diazepam to a patient, it can cause phlebitis and thrombosis, so you really need to be looking at that IV site. And it is teratogenic, so you would not want somebody who is pregnant taking these. You always, when you have a pregnant client, always have to look at what the medication can do, what harm can it cause, and then you always have to weigh the benefits versus risk. So interactions, we talked about this, other CNS depressants. So alcohol is a big one. So this would be something you would want to tell your patients, just be sure you're not drinking alcohol while you're taking this medication. Then there are a couple of other things that I noted. One is if you smoke, it will decrease the effects of the benzodiazepine. And kava, which is, it's an over-the-counter supplement that people can get. It actually can increase the risk of sedation if somebody is taking a benzodiazepine. So teaching for benzodiazepines. So we really have to think about those safety things too. We are decreasing that CNS. It can make somebody a little bit dizzy, more tired. So we want to tell them to change position slowly. Because they're at risk for falls, think about all of those fall precaution teaching interventions you would do: non-skid footwear, appropriate lighting, clutter-free environment, no throw rugs, because those increase tripping, falling, that type of thing. Because there is an adverse reaction of memory impairment, you want to check their memory to make sure that they aren't having any issues remembering. and assess for tolerance of dependence. So again, this comes with withdrawal if they stop it abruptly. So we do want to taper the dose over 1 to 2 weeks before we stop it completely. If you are giving IV medication, if you're giving this in the hospital, we want to make sure that we have airway and blood pressure support if needed, which you would have in the hospital setting when we are giving any type of CNS depressant. Then we have non-benzodiazepine treatments for anxiety, and buspirone is the medication that they have given you. The things that I noted, and I really hope that you guys are looking at your module and kind of taking some notes before you're watching this and then comparing to make sure that we're pulling some of the right things. That way you guys will know that you guys are grasping the same things that are really important. And again, I think I've said this in previous videos, when I look at these medications and I go through these charts, I really try to look at what questions are out there in NCLEX books and on different, sites to see what are they pulling, what are the most important things they, really are feeling that you should understand about these medications. And these are the things I'm pulling. So you guys should be practicing, going through the module, taking some notes, not writing every single thing down, but see if you're pulling the same things I am. So this is a short-term treatment for anxiety. It has a very delayed therapeutic effect. So that is something you would definitely want to make sure that your patients are aware of. This is not something they're going to, feel relief of symptoms right away. It is going to take some time for it to work. And then you want to avoid some things when you're taking this medication, including grapefruit juice. So that is something from Module 1. If you guys remember that grapefruit juice can, it can impact absorption of medications. So we want to make sure that they're avoiding that. And then erythromycin and ketoconazole also interact. And then MAOIs, which you will see a lot of medications that interact with MAOIs. So I will say that I don't really, in practice, even when I was there, I did not see a lot of patients on MAOIs just because there are so many things that interact with them. So we'll talk a little bit about depression. I'm going to tell you right off the bat, with depression, if you put somebody on antidepressants, they are depressed, you need to be assessing for suicide. Every time you see this patient, you want to assess for suicide. Do you feel like you want to harm yourself? Do you have a plan for harming yourself? That type of thing. If you have somebody who is actively suicidal, that is somebody who should not be left alone, okay? So we talk about treatments for depression. There are multiple classes of medications that you might see. Tricyclics, SSRIs, you might have a serotonin norepinephrine reuptake inhibitor, the MAOIs, and then there are some atypical antidepressants. So symptoms, again, I'm not going to read this whole list to you. You have to understand what you're treating at the, I know that you guys haven't learned some of these exemplars yet as we go through them, but just very base knowledge. What is depression? What might you see? Okay. It is more than just feeling sad over a situation, right? Because a lot of people can suffer situational depression, like if there's a death in the family or something like this. This is a diagnosis that somebody would have where they're having these feelings on a regular basis, right? So we want to make sure that they're receiving treatments for this. So if they're on a tricyclic like amitriptyline, you want to be very cautious if the patient has had any cardiac issues, especially recent MI or cardiac dysrhythmias. Okay, this would be a medication that really we would not want to be using this medication for that patient, or if they have a seizure disorder history. Okay. Interventions, if somebody is just starting amitriptyline, we might check some orthostatic vital signs on them. Always, if we have somebody being treated for depression, no matter what the medication, we are assessing suicide risk. With this particular medication, we want to assess for withdrawal symptoms and assess for signs and symptoms of overdose, okay, which can cause dysrhythmias, which is why we don't want to give it to somebody with MI issues. It can also cause seizures, so you don't want to give it to somebody who has a seizure risk, okay, because they would be at a higher risk for these symptoms, these adverse effects, okay? And so when this is given to a patient, usually they're only going to give them very short-term dose, like a week, and then reassess. Now, if you have somebody who's very seriously depressed, you're worried about that suicide risk, even if they don't have a current plan, they're not actively suicidal, we still need to be very cautious of that, okay? And so we would also want to be educating like a caregiver if you're prescribing these for, somebody, if they have a family member, and especially if it's adolescent, you want to be educating their caregiver. SSRIs are the big ones that you hear a lot about. These are the teen ones. Fluoxetine is the one that they give you. Again, we're assessing that suicide risk, okay? These ones can cause weight gain. They can also cause serotonin syndrome. Okay, so we want to watch for symptoms of that. Interventions, again, assessing suicide risk. We want to be checking weights. We want periodic serum sodium checks and assess for those signs and symptoms of serotonin syndrome, which can be fever, anxiety, agitation, and hyperreflexia, okay? So those are the things we're watching for if somebody is on an SSRI. And I got to tell you, I think that, if I just go back a slide here a second. Oh, it's not going to let me. Oh, there it goes. Those are huge things, okay? So we talk about with any of the antidepressants, assessing that suicide risk. But with the selective serotonin reuptake inhibitors, so it's inhibiting the serotonin reuptake, we have to watch for that serotonin syndrome, okay? So those symptoms, if you have somebody on this and all of a sudden they're experiencing unexplained fever, anxiety, hyperreflexia, we definitely want to be aware of that. MAOIs, okay? Phenelzine is the one that they give you here. This one, I don't know if you guys, I know you'll talk about it again probably in third semester, but because this impacts tyramine, you want to make sure that patients are avoiding foods with tyramine, okay? And I will let you guys, pull up a list of medications, including tyramine. See, did I give it to you? I didn't give it to you here. So you can look up food, like a list of foods that contain tyramine, but it's basically like aged cheeses, wines, cured meats, anything fermented. There's some sauces like soy sauce that have tyramine in there. So if they're having a lot of tyramine and on this medication, it can actually put them into hypertensive crisis. Okay, very high blood pressures. And if you guys have already talked about hypertension, which I believe you did in second semester, you should know that if somebody has uncontrolled hypertension, it puts them at risk for stroke, okay? Again, we're assessing suicidal ideation for a patient with this. If they are actively suicidal, this is probably not going to be the best medication to put them on. We also, so I think I said in a previous slide, a lot of times the MAOIs are avoided because there are so many contraindications, interactions with them. So again, if a patient has liver disorders, cardiac disease, if they're, over 60 or under 6, if they're already on an SSRI, if they have alcohol or drug addiction or glaucoma, this is a medication that would be contraindicated. Okay, so there's a lot of interactions. So don't quite see the MAOIs used quite as much. Again, adverse reactions, hypertensive crisis if taken with tyramine-containing foods. So you might have a patient, that was coming into the hospital with high blood pressure, and you see that the patient has been taking this or is prescribed this drug. A question you might ask as a nurse is, what types of foods have you been eating? And then you could ask them, even more specifically, have you been having any aged cheeses? Because they may not understand that it is that they should be avoiding those foods. Okay. Let's see. Lithium. Lithium is a big one that I've seen a lot of questions on when I go through and search for questions for, NCLEX. This one has a narrow therapeutic index. So if you remember from Module 1, medications with narrow therapeutic index, that means the dose that is going to be therapeutic versus the dose that is going to be toxic to a patient is very narrow. right? So when we have that narrow therapeutic index, we need to be checking drug levels. So if you have a patient on lithium, you need to be telling them, you need to expect that you're going to be having your blood drawn fairly routinely, just to ensure that you are on the right dose. So what can you see? This is drug therapy for bipolar disorder. If you don't understand what bipolar disorder is that you see sometimes these, a patient can go from severe depression to almost manic, high mania states. So it's this kind of swing between the two states, okay? Low sodium diet can cause toxicity, so you want to make sure that their fluid intake and their sodium intake is pretty balanced, okay? So that they are maintaining that level. And most of us will, but if you had, so let's say you had a patient on lithium for bipolar disorder and maybe they're on, a heart healthy diet. And so on their heart healthy diet, they've always been told to avoid sodium and not to drink a ton of fluid. Well, that would be a concern for this patient, right? Because it could put them at risk for a toxic dose of this medication. So this would be somebody, again, if you're doing routine blood draws, they may be checking, a Chem 8 as well, just to check that sodium level. But you would want to make sure that they're eating a normal amount of sodium, okay? So normal amount of sodium is like 2 grams a day, 2 to 4 grams a day would be okay for a person without, any significant history, and then ensuring adequate fluid intake as well. So drug therapy for schizophrenia, chlorpromazine is one that you may see. If you don't understand what schizophrenia is, sometimes this is something that is not diagnosed, and quite often it's not diagnosed until a person is a little bit older, late teens, early 20s, but it's for a person who interprets reality abnormally. Okay, they may hallucinate, they may have delusions, disordered thinking, so you might see some childlike behaviors like laughing completely inappropriately. They may have a bizarre posture or gait, lack of response, and they can also have suicidal thoughts and behaviors. So this is a disease of the brain, okay, that really needs to be treated. So you might see somebody on chlorpromazine. Adverse effects include Parkinson-like syndrome. So Parkinson is that shuffled gait. They can have tremoring with a Parkinson-like syndrome. Severe cardiac dysrhythmias. They can have this neuroleptic malignant syndrome. And with that syndrome, they can have a high fever. They can have, irregular heart rate, increased respirations, muscle rigidity. You can see all of that with the neuroleptic malignant syndrome. And they can also become very sensitive to light. So you can see that photosensitivity. And then I know this is kind of outside, we've been talking about like mental health disorders, anxiety, depression, schizophrenia. I know this is kind of a weird one to be thrown in there, but it also falls under that neurological system. So glaucoma is something we'll talk about as well, okay? This is increased intraocular pressure, okay? And you will learn more about beta-adrenergic blockers later, but you can see those, and you can also see cholinergic agonists like pilocarpine, okay? So we're going to talk about pilocarpine because you guys will learn more about beta-blocking agents in a later module. So with the pilocarpine, what this does is it constricts the pupil. Vision is impaired, especially at night. So if they're using this, I have the image of the nightlight here because they're going to have impaired vision. Remember, we always have to think about safety. So when we think about safety, we want to make sure that if they're not getting in as much light, that we provide as much light as we can, okay? They want to remove contacts if they wear contacts. They want to remove those prior to inserting the eye drops. And then just going back to proper administration of the medication. So they will want to hold pressure on the puncta and nasolacrimal sac. So that's the inside of the eye next to the nose. So they want to hold that for 60 seconds to prevent systemic symptoms. So systemic symptoms of this medication are bradycardia, bronchoconstriction, and urinary urgency. So I have to tell you a little story talking about adverse effects and really picking up on things with patients. I saw a patient come in while I was in clinical with students who came in with a heart rate in the 30s. Okay, and so she was very symptomatic. She had been passing out, and so she came in, and we're looking at her medications, and I said, you know, is she administering her eye drops correctly? Because they were getting ready to work her up for, you know, pacemaker placement, all of this other stuff, because they weren't finding a cardiac, like an underlying cardiac diagnosis, like a sick sinus syndrome. They weren't finding that. It wasn't a block. She was just in sinus bradycardia. Okay, so sinus rhythm, but low heart rate. So that's sinus bradycardia. You know, and then you have to look at, you know, what could it be? What could be causing this? And I think a lot of people weren't thinking about that eye drop. It's like, yes, this can actually have an impact on the heart. And if she was an older woman and she was doing her own, so maybe she's squeezing the bottle too hard, giving herself more than one drop. And it could be that she's getting that systemic response because she wasn't, you know, putting the pressure. So you always have to be thinking about stuff, you know, as you're seeing patients and they're presenting and they come in with medications. If they have, you know, symptoms and you're not finding a medical diagnosis that, you know, really correlates with those symptoms, look at their medications. You know, are they experiencing some adverse effects? You know, because it's not always the first thing that people think about when it's an eye drop and you're looking at bradycardia, you know. So anyway, just a little FYI on that. And that's it. Again, make sure you guys are, if you haven't already, go through the module. Remember, repetition is key. You have to keep looking at this stuff. You know, going through those modules, doing the activities in the modules are going to be very helpful. When you guys are doing your own medication list for, like, again, you don't have to hand them in. It's for you. Make sure you're not copying and pasting. Okay, that's not helping you. Write things in your own words. You know, shorthand, and really note what you think is most important off of those drug sheets that you get in ATI. Okay, hope this was helpful.